Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we have Professor Rui Riberio with us from Portugal. Professor is a teacher of teachers. He's a great surgeon, great bariatric surgeon, great mentor, and also his participation, especially for promoting bariatric surgery, is really appreciable. So you can see Professor at any international conference, any international committee is active participation, sharing knowledge. Always we can see Professor is there. My viewers, we have completed our four interview series, and now this is our fifth interview series that is about revisional bariatric surgery. In my opinion, this is one of the most important one because nowadays we can see more and more revisional bariatric surgeries. This is a time to talk about this, and in near future we must standardize, need guidelines. So I will not take time, sir. Really, so much thanks, so much thanks. Always you are supportive. I know you are so much busy, but always you are with us. You are at GLR TV, and also we need your support, sir. Please.
Okay, first of all, thank you so much for this kind invitation. It's really an honorable time to be with you again and to be able to share our ideas and our opinions and practices with you and try to spread it all around the people that are taking attention to this kind of talks. They are very interesting. We know about that. Indeed, the revisional surgery is something that is very valuable for me because I've been doing that for nowadays 21 years. In reality, I began with gastric bands in 2000, and in 2002, in the end of 2002, I performed my first gastric bypass. It was my really first bilaparoscopy, and it was a band with a complete slippage and an obstruction of the stomach, and I had to operate the patient. And I went for a bypass. It was really tough at that time to do that kind of conversion. I took 7 hours in order to have the idea. I've been training before, of course, in animal models and in the endotrainers. I operated some pigs before with gastric bypass, but anyway, it was really a challenge. But it went good, and following that one, in the next year, I began with primary cases and went forward with revisionals. As in the beginning, we have put more than 1,000 bands in my team. At that time, in a public hospital, we had a lot of revisions, as you can imagine. So all along the year, I suppose me and myself and the team, we removed more than 700 bands, doing every kind of modifications. So there is a landmark in 2014. I changed to another hospital into my hospital group, still in the public service, and that was the biggest one in Portugal. We were operating 500 patients a year at that time, and at that time, 48% of our practice was revisional surgery in 2015. Why? Because we had a lot of bands before, we had also some sleeves, we had also some gastric bypasses needing revisions, and mostly because it was in the public service, and everybody that was operated in the private services came back to us to solve their problems because it was cheaper, it was more convenient financially for them. So we took a lot of education how to deal with the most difficult situations, and some are really, really dramatic sometimes. But well, I'm available for your questions, and I hope it can be useful for someone to share our experience.
Sir, so much thanks, really, and this is great honor to interview such a person who has more than 2 decades experience, and also especially experience of revisional surgery. Sir, in different international conferences, so we can hear about revisional conversion, correction. So how you can define this?
Well, I use a bit different classification. Usually, we use revisional surgery for every kind of reoperations or operations in people that have been operated before. That's why our revisional surgery or redo surgery in the short term. Into that, we divide them in conversion surgeries. It means that we begin with one operation, with one technique, and in the end, we transform, we modify to another technique. So that's a conversion. It can be from sleeve to bypass, can be from bypass to sleeve. We have done both. We have what we call the properly revisions. It is, I'm going to approach a bypass with a dilated pouch. I trim the pouch. In the end, I have the same operation, but with upgrade, if you want, and we call that revisions. And finally, we have the third situation. It is when we have an operation with problems, for instance, hypoglycemia in a bypass, and we go to the normal or the most proximal situation to the normal anatomy. So we come back with the operation, we undo the operation, and that's what we call reversion of the surgery. So we have three: conversion, revisions, and reversions.
Sir, so much thanks, sir. Sometime we also hear about failure of bariatric surgery. Again, definite this failure of bariatric surgery. So one bariatric surgeon can define, and also from the patient view, because unfortunately, sometime when we talk with our patient, because we have a lot of our viewers, youngsters, so this will be also message for them. When we talk with the patient before surgery and just imagine, we ask them, yes, you will achieve this target, so diabetes will be like this, weight will be like this, to attract more patient. So due to this, so maybe patient achieve more than 50% weight loss, but not that one that patient was imagining. So how we deal with the patient, how we talk with the patient, how we define this failure of bariatric surgery.
Well, as you said, there are some cutoffs about metrics and trying to define failure, but I suppose it's a bad method. We shouldn't go on that track. You know the Reynolds criteria that you commented on. So a patient is a success when he loses more than 50% of the excess weight loss. Okay, it's a definition. I've used it for a lot of time, but or if you want more than 10 kilos, or the best one for me is to get the BMI lower than 30, because obesity is a BMI about 30. So if you want to treat obesity, if you are in bariatric surgery, metabolic is different, but in bariatric surgery, the patient needs to be under 30. And in that case, I suppose it's a success. But more than this, we need to define with the patient some kind of, I can say, we need to regulate the patient expectations in the beginning and tell them, you need to lose 20 kilos or 30 kilos in order to improve your quality of life, in order to control your diabetes and so on. And that's different from percentages or cutoffs. So sometimes, as we know, to lose 10 kilos is a great advantage for a kind of patient. So it's a success indeed, because it is able to control a set of diseases, and that patient improves a lot. And sometimes they can lose 80 kilos in very heavy patients, and they don't improve their diseases. And that's the most important, I suppose, the control of the associated diseases, and secondly, the quality of life. If I look back to my consultation yesterday, I had a patient that is with a very low BMI, with 20.9, and she's very happy. I look at her and I feel she's a little bit thinner, okay, not so not so brilliant as usual other patients are, but she's very happy, okay. So it's a success. In other words, I had a patient, later on, I had a patient with I know AGB that has got only a BMI, she came from 45 or something like that, and she came up to 33. 33, okay, according to the rule that I commented before, it would be a failure, but it is a failure indeed. And when I went put the questions on the patient, I understood that she was not compliant with the nutritional rules and she was not exercising. So it was a failure in the criteria of BMI and also in the behavioral component of her life. So I suppose that we need to, if the patient is okay, fine, is happy, we can have failures. The patient has got his goals. If the patient is not happy, well, maybe even with some cutoff we cannot say that we are not having a success. That's it. So it's something very variable, and we need to define it with the patient.
Sir, so much thanks. Definite so failure of bariatric surgery is a wide definition. So we cannot correctly define. It depends on the surgeon view, also
In the
patient.
patient view.
Then yes.
Yeah.
Sir, this revisional bariatric surgery is not initial bariatric surgery, and definite when we do this, there is a lot of adhesions, a lot of challenges in revisional bariatric surgery. So we are interested to hear from your side. What is the technical consideration for revisional bariatric surgery? So when
Well,
we're doing,
technical.
someone is going to do, so definitely he can face adhesion, he can face a lot of adhesions of left lobe, he can face some migration of his sleeve, and many things.
Sure.
Yeah.
Yeah, myriads of things, different ones. I would divide those technical issues in three parts. Preoperative issue. First of all, we need to understand very well the operation that the patient has had before, and to get the protocol if possible, and to do a very good study with imaging, with the X-ray, with a barium swallow, or with a CT scan, or ideally with a CT scan with a tridimensional reconstruction in order to get some kind of image of the compartments of the operation, pouch, anastomosis, esophagus, and so on. Also, the labs are very important. We need to evaluate very well the biologic situation of the patient, mainly in the nutritional aspects. If he is malnourished, if he is well nourished, if he is hydrating, how are the ions, how are the vitamins. Well, if he has Helicobacter pylori again, we need to treat it again. So we need to evaluate the patient very carefully in the laboratorial aspect also. And also, with the multidisciplinary team, we need to reevaluate his capacity to understand what he needs to do after the operation, after the reoperation, and what we call the behavioral rehabilitation with the nutritional. The patient needs to understand what he needs to change again in his habits, and in the physical aspect also. Try to push patient again to some kind of physical activity that can improve the quality of his muscles, getting a more trained and more effectively consuming calories, muscle. That's very important also. And if the patient is able to modify his habit, we can go forward with the service. The patient is completely indifferent and is not paying attention or not able to be competent about those asked modifications. We need to think if it is valuable to have the risk of an reoperation for a patient is not being effectively compliant, and maybe is not having good outcomes again in the future. So we need to think about that preoperatively. In the operation, different aspects. For instance, how to do the pneumoperitoneum. Some people use the optical trocars. I use always the varus needle in the palmar point. Why? Because it's the point where very rarely there are adhesions. So it's a very safe place to put a varus needle and to have an initial pneumoperitoneum. And after that, put a trocar nearby and try to get space, because you can have a completely sealed abdomen or peritoneum, and you need to create a kind of a bubble, and you begin to dissect that bubble, and in the end you can end with all the adhesions cut and with a free abdomen. So, but that's art and situation. Sometimes we need also to, if the patient has a scar, or more important, scars on the left, you go from the right, or vice versa. The first trocar should be always an optical trocar in order to see what with the planes of the abdominal wall, and to avoid hollow viscerous injuries. So be careful about also. In the adhesion, in the adhesiolysis, that is the issue, the first difficulty that we face in visual surgery, and it's sometimes very tough. We can take 10 minutes or 2 or 3 hours doing that. The main rule, I would say, is to use the minimum of energy, as we used to say about the incisional hernia laparoscopic treatment. So try to avoid the cautery or even the harmonic scalpels, because the thermic injuries are really dangerous, and you need to avoid that. What else? We need, of course, to check compartment like the hiatus, if it is completed or not, about the pouch dimension and caliber, if the pouch of one bypass or one sleeve is dilated or not. So we need to dissect and to individualize the structures. That's very important. And here the main rule that I have, let me say something different. I've been in the first Congress performed in the United States about divisional surgery. It was in Nevada, very far, Lake Tahoe, and all the important American surgeons were there at that time. And it was the first time they met to talk about revisional surgery. And the main message that I've got there was, be careful about the vascularization of your organs. Don't cut the vessels too much. Don't desvascularize a pouch. It will be a big problem, or the bowel, or the esophagus. Okay, take care about vascularization. Please keep your organs safe. And I suppose we need to have every time that idea, that light in front of our eyes. And of course, be careful about hemorrhages, and try to be so economic in your movements as you can. Don't go more further than what you need. You need to have that point, because in all thing in the world, we need to perform, and that's what I say to my patients. I will perform on you, because in the beginning, sometimes you need to explain, I'm going to try to do this operation or to convert to this operation, but if it will not possible, maybe I can have the need to go for another one. And the patient must be advised about that before the surgery. And if you need to change, please don't cut more than you need to change for what you are able to do it, but keep the patient safe all the time. Well, usually if you have more hemorrhage that you would like, put a drain in order to control it. If you are going to perform suture lines, staple lines, reinforce it in order to avoid hemorrhages, because sometimes the tissues are thick, there are a lot of scars, and sometimes the staples are not good enough to control the hemorrhage or the fistula even. So defend your patients also doing over sutures of the staple lines is very important also. Don't forget about that. And well, probably there are more technical aspects, but those are the more important in the operative time. And in the another important issue is try to control the time of surgery. Obese people don't like long operations, so please avoid to perform operation more than 3 hours, 4, 5, 6, 7. It's not good for them, because because of the thromboembolism, first of all, because the risk of infection in the future, because of the hypothermia, because of the myoglobinuria, and so on. Okay, so that's important to have not very long operation. In the post-operative period, I don't do it at all any kind of barium salts after the operations. But in revisional surgery, maybe it's a good idea to do that. Not with barium, of course, with gastrografin, but try to have some to check the integrity of the anastomosis, or look at the continence of your drains, bottles. So take care about the patient. And first of all, those patients need to be very, very quickly nourished. Put them as soon as possible with proteins. High levels of proteins will provide a good cicatrization and keep the patient more able to recover quickly. So I suppose there are some ideas about the revision occasion.
Sir, excellent, really excellent, and definitely it was a great message. Especially personally, I learned a lot, and as well as our youngsters. So this revisional bariatric surgery is not simple. This is not
No.
initial surgery. So as Professor mentioned, you must start. That was the biggest, in my opinion. So you must talk with the patient that behavioral therapy. This is not only you will go and do surgery, and this is not the magic. If patient consult to you with weight regain after sleeve gastrectomy, definitely we must talk with the patient to change healthy lifestyle and go to healthy lifestyle. If we will not start again, and again. So this is a very
Sure.
important. Prepare the patient. Then there are some issues during surgery and as well as after. Sir, just a scenario, because nowadays where I am sitting here in Dubai in Middle East, the most common surgery until at the globe is sleeve gastrectomy till this time. And as you have mentioned earlier, so you did hundreds of revisional surgery after gastric band. And nowadays, same thing we are dealing with sleeve gastrectomy, especially in our area, unfortunately. And lot of cases also after weight regain and also GERD. So now we will start with because this is a common thing and definite our young fellows, and we are always facing such a situation because now here we removed many bands, but now there is no one who is doing gastric banding, and definite very rare. But a sleeve is still a leader of bariatric surgery and most common, especially this point of view, is a leading surgery. Sir, weight regain, just imagine patient, this is a common thing that I am personally also facing. Sometimes patient consult to you with insufficient weight loss. So he did surgery in another facility. When you see, so you did some barium studies, and there was a big pouch that was not standard sleeve. So just this patient consult to you after 5 months after initial surgery, and the patient is a young patient, so 35, 40 years age, young, and now patient just lose 20 to 25% excess body weight, and just now stop and starting to gain weight. Just imagine patient was 135, they did this, that was not standard sleeve, big pouch. Now still 5 months, first 3 months, yes, lose some weight, again stop, and now patient is 120, 115, so from 135. So what we do in this case? It is need to rush for surgery or no? We must wait. We can do something for such a case that there was not standard sleep.
Yeah, that's a very important issue. But before going approach to that answer, let me see something that I forgot to tell everybody. It's very important that you need to measure very well your technical capacity for an approach of this kind in revisional surgery. And if you are not confident to do the operation that the patient needs more, don't do a minor operation because you are not able to do what is indicated. So if you are in that situation, please ask someone more experienced to assist you, or go to operate with some people in another hospital, but don't put the live patient in risk, neither the good outcome of an operation. That's an important message also. I forgot to tell about that.
Definitely.
Well, insufficient weight loss is not so common, at least in our practice. Anyway, there are some kinds. I suppose that most of the cases have insufficient weight loss are wrong indications for surgery. We know that for sleep, there are, I do a very few sleeps. Why? Because I suppose that the rate of weight regain or sufficient weight loss is higher than I would like to. So I had a typical profile: young people, physically active, clever enough to understand what they need to change, and compliant to the follow-up. That kind of patients, okay, I can put them on a sleeve if they are not super obese, of course, or even more than 45 BMI, because those we know that are not getting outcomes. So if you are going to do a sleeve in a super obese, of course, you are going to have an insufficient weight loss. But that the mistake is not the sleeve, it's the indication, okay? Yeah. That's important, in my point of view. But when that happens, and if the indication is okay, is well chosen, what can we do? In the case of sleeve, we need to, first of all, to take a look to the nutritional habit of the patient. If he's a sweet eater or if he's how is the name, binge eater, well, you need to modify that before, because sleep is not enough for that kind of patient most of the time. So, okay, send him to the nutritionist and psychologist, try to change him and explain that if he doesn't change, you need to perform another kind of situation of operation. In that kind of situation, we need to check very well the dilation of the sleeve, which is very, very common. We can have three types of dilation. Dilation of the fundus, like a mushroom, the neofundus, it's more usual one, and it's due, as you know, because of insufficient dissection and resection of the fundus in the first operation. Dilation of the antrum, which is also very common. Why? Because in the beginnings, when people were not so familiar with the good technique for sleep or with the perfect sleep technique or concept, the antrums were bigger sometimes than what was needed. So, usually I begin cutting the stomach below 4 centimeters, sometimes 3, sometimes 2, but at least 4. If you go above, you are going to have too much antrum and it will dilate more easily in the future. And sometimes we have combinations of the neofundus, of the antrum, and of the body of the stomach. Sometimes it's all the pouch that is dilated. But the worst is when they have torsion, because of reflux is usually the consequence. But in some cases, maybe with a big fundus, re-sleeve can work. But anyway, I suppose it has been shown and demonstrated by different authors that re-sleeve is not a good operation. So I don't do re-sleeve usually. I can do a re-sleeve, but I add something more to the situation in a sufficient weight loss. And more than that, re-sleeve is a dangerous operation because, again, you are going to cut on scar tissue with irregular thicknesses, areas, and we can have problems about leaks. The leaks are 3 or 4 times more frequent in re-sleeves than in the first sleeve. So, and leak, it's not a nice thing, as you know, to see. What do I like to have in a situation of sufficient weight loss? Well, if there is, I need, the concept is to put some ileal kind of, some type of ileal surgery, ileal overstimulation. How can I do that? With converting to a SADS, it's a good option, okay? If the patient has not reflux. If he has gastroesophageal reflux, I want to go for that. If the patient, another option could be what I would like to call OATB, oneness was transit bipartition on SASI. Okay, it's a good operation also if there is not reflux. But what I found in that kind of operations in my practice is that the weight loss is not so good as the primary cases. It's not so good as with the SADS. So it's not my first option. My first option is SADS in that kind of insufficient weight loss. Some people like to transform to go for OAGB. Well, theoretically, I have nothing against that. I'm a big OAGB fan, like a primary surgery, not like a revisional one. Why? Because in the principles, when I began to build OAGBs, I made some kind like 20 cases of revision OAGBs, and I have an high percentage of bioreflux to the esophagus. That's the problem. And why? Because any sleeve, any band, of course, will provoke an hypertension of the GA junction and the anti-reflux mechanism, and it will damage it. So, and with OAGP, you're going to put bile or some bile, diluted bile as you want. It's not a big problem on the stomach. It's not a problem really, but in the esophagus, it will be easier to go up to the esophagus, and I don't want that to my patients because that's dangerous, as you know. Well, so I don't do OAGB, but in that case of situations, I've done a lot of diverted OAGB. The operation that I proposed in 2019 in a publication in obesity surgery, and that I began in 2013, is actually using it as a rescue for people with restrictive surgery like band or sleeve with weight regain or with insufficient weight loss and reflux simultaneously. It's a good operation to deal with both situations and with good outcomes. In the publication that I done in 2019, I had about, I suppose, 35 or 40% of the patients, they were 400 patients, were revisional, and the outcomes were very good, even in the revisional with that kind of surgery. So that's it. And another option is the classical transit bipartition in case of reflux. But we are not putting bile on the stomach, on the pouch, but anyway, there is a sleeve, there is a big pouch, the acid production will be bigger, and I suppose the risk of gastroesophageal reflux will be again present. So, resuming, insufficient weight loss or weight regain without reflux, yes, maybe OATB, TASI. Weight regain, insufficient weight loss with reflux, diverted OAGB or transit bipartition.
Sir, excellent explanation. Definite. It was again a great message, sir. When you will go, when the time is very important. So this patient was just 5 months after initial surgery with insufficient weight loss, with dilated pouch. Are you wait for this? You will do any just conservative therapy or no? Then you will go because you see there is insufficient weight loss, dilated pouch that was not standard sleeve. So patient is still suffering with the same issue. Are you wait till
Okay.
1.5
Yeah,
years?
yes, nowadays I had some kind of patients mainly that came up to me from Brazil. They performed their operation there, they came up with a sufficient weight loss. I had some patients in that situation, and I do like to try the medical therapy, of course, also with the nutritionists and the psychologists always, and I don't give the medicines myself, because I want to involve another profession that is endocrinologist. Okay, so nutritionist, psychologist, and endocrinologist. The patients go to them. They are again taught about what they need to do, and with the medicines, we have got some interesting outcomes. But unfortunately, sometimes they are provisional. They have some weight to gain, but they stop again. And in those cases, of course, I go for an operation. If some patients are very, I would say, very hard in order. No, this operation, I don't want this operation. I want to do another one. Okay. If this is not a very difficult case or a very dangerous case about the pathology and so on, the cardiac and the respiratory risk and so on, maybe I can go directly for a reoperation immediately. But I suppose the patients need a second chance with the medicines nowadays.
Sir,
in the postoperative periods.
Sir, nowadays we can also see the role of endoscopic bariatric surgery. And if we step this, when such a case with weight regain are insufficient, especially because now we are talking insufficient weight loss, so we can give some medicine like GLP-1 derivatives or analogs or some diet protocol. So are you think so maybe in near future or just now we can also ask the patient to do some like endoscopic gastroplasty or something like this, maybe decrease the size of pouch and increase restriction, and then so we will decide for next or no need to go for endoscopic intervention.
Well, I suppose that the endoscopic techniques have a role in the obesity and metabolic diseases treatment, of course. Of course, they have some power, they are good, they can have some outcomes, but not for the more heavy patients or the more metabolic patients, I would say better. Um, and I suppose they can be used. We have the pyramid of the obesity, as you know, and we are operating the top of the pyramid. But the inferior levels with the people with BMI with between 27 and 30 or something like that, 31, 32, I suppose they can be enough good candidates for endoscopic arthroplasty. Okay, I accept that. But I used to say to the patient, but be careful because the risk of weight regain in the future and recidivism is very high with that operation. Even today, I had a patient that had performed an endoscopic arthroplasty. 1 year ago, she has lost 20 kilos. She was happy for 9 months, and between the 9 months and the 1 year was operative, she regained all the weight. So she's desperate with the situation, and of course our colleague that put the endoscopic operation on that told them, and that's ugly. Oh, now I can't do any more for you. Sorry, I suppose that you need to behave better. But I suggest you to buy a book. So the power of the mind in order to control the situation. That's very ugly. And this drives me to the concept that the people that are performing endoscopic arthroplasties are not really obesity experts. They don't understand the disease most of the time. They don't have a multidisciplinary team. They are not focused in the obesity and metabolic disease treatment. We know that the good outcomes come from people that they are doing this activity in 80% or 90% of their time. That's very important. And even some sessions I see, sometimes I'm not politically correct. They don't understand very exactly the patient, the disease that we are dealing with. But anyway, I suppose that for class of patients, it can be good enough. But about 35, for sure, it will not work because endoscopic arthroplasty is my view, and the time, I suppose, let's see if the time can check that or not. It's only restriction. And all the history of bariatric surgery, if you look back in the past, all the restrictive techniques failed. Mason operation, the Roux-en-Y gastric bypass even, the gastric band, the gastric plication, the surgical plication failed most of the time alone, of course, because we know that with the gastro-ileal anastomosis, it works good.
Yeah.
So I suppose that even sleeve will not disappear. It will stand in the future, but it will go down in the future because we have now better and even safer operations than sleeve. So in that kind of patients, I suppose that restriction by endoscopic techniques will not be the future. But we are now facing something that we call the magnetic surgery. And in that concept, I do believe that in the future it can be important because with magnets, we can perform anastomosis and we can perform the ileal stimulation, getting better metabolic and weight outcomes.
Sir, excellent, excellent, definite. I absolutely agree with you. So, because obesity is a chronic disease and obesity is a multifactorial disease, so we cannot ask only with restriction, so we can achieve the target. but definite we add some that hypoabsorptive component, and we stimulate terminal ileum and rise of GLP-1, GY, it is PYY, GPI, GIP, and so these hormonal changes then definite that are anorectic, and we can achieve those targets. Sir, just another scenario: a patient with weight regain, there is no GERD. Patient with weight
Mhm.
regain, that was standard sleeve gastrectomy. Just you did sleeve gastrectomy 4 5 years ago. Now patient back to you with weight regain, that is sufficient weight regain, just 35 above than 35 now BMI, and you have decided to go for surgical intervention. You did everything, but patient is heavy smoker. So now you have two option. So one option, you must go for Sadi S, because in smoker there is more chance of marginal ulcer if you will go for any type of gastrojejunostomy. So another option, you can go for one anastomosis gastric bypass, but with truncal vagotomy, because patient will ask you, I will not smoke nothing, but again patient will smoke, because this is also my bitter experience. What do you prefer in this case? Because there is no GERD, you can go for Sadi S. And definite, when we will do this duodenal so you know better than me, there is less chance of marginal ulcer as compared to when you will go for gastrojejunostomy. Sir, please. I like
Well,
from your side, especially about truncal vagotomy. What's your opinion?
I have no experience with truncal vagotomy in this set, so I don't know exactly how valuable it is. So I would like to have more data from the literature about the valuable of that situation. What I can say is that my option is definitely SADS. Because why? Because the duodenal ileostomy is not prone to have ulcers because of maybe of the mucus and so on that defends the patient. But let me say that before of all those concepts or discussions, I would try to convince the patient to stop smoking, okay?
Yeah.
And sometimes I do that, explain them that, and sometimes trying to frighten them that, well, you can have a perforation, you can have horrible pain, you can have hemorrhages, and so on if you continue pain. But, okay, it works in some patients only. But study is definitely my option. About vagal uh, uh, interruption, well, maybe I'm going to defeat to make some prejudice in other functions of the bowel. So I'm not sure. I've never done it. Maybe it's effective. Probably it is effective, like in the old times of the outdoor surgery. But I don't know. Another option in some kinds of operations in OGB and in Roux-en-Y is the remnant resection, okay, the gastrectomy, in order to avoid the gastrin to production and try to diminish, to reduce the acid production, chlorhydric acid. So, but I have seen some cases that it didn't work at all, first of all. And secondly, is something that I don't like. It's very radical operations that have no exit strategy. All that I do, I try to leave open door to a kind of problem. So, and if you remove the stomach in a bypass, you have a short pouch, and if the patient has another author, and I had a couple of cases like that, that's why I have that philosophy. You have a short pouch, and you need to go for esophageal jejunostomy or something like that, total gastrectomy. And well, it's not a big issue, I know, but well, I would like to avoid that kind of situation.
Sir, so much
That
thank
yes is my answer.
yeah. Sir, another question, because also we routinely face GERD after a sleeve gastrectomy. So because that is also common question, and also there is already standardized. But for my viewers, so we are interested to hear from your side. So patient with intractable GERD, but BMI is low. Patient BMI is now 23, 24, because he lost weight after a sleeve gastrectomy, but suffering with GERD. So what you will do? Surgical. Now you're going to do surgical intervention in such a
We,
case.
With the sleeve or a bypass?
No, sleeve, sir. We did sleeve
Sleeve.
gastrectomy.
Very
Patient
clearly.
BMI
No,
is normal range. There is no obesity.
yeah. I suppose it's one of the few consensual opinions in this field. Ruan gastric bypass.
Yeah. But
It's the
BP limb,
operation.
sir.
It's not the.
BP limb,
Yes.
how much BP limb in this case when there is a patient
If
BMI?
the patient is low BMI,
Yeah.
we can do it with 80 centimeters, 1 meter, maybe.
Okay.
BP limb.
Yeah.
And at least 1 meter of alimentary limb in order to avoid the backflow of bowel content to
Yeah,
the.
bile, definite. We need elementary limb must be that especially rule limb that must be long
Yeah.
and so forth
A little bit longer, yeah. Not
long.
on Fifi, I suppose it's not necessary so much, and because I suppose that having an alimentary limb, I'm a great fan of the concept of one anastomosis, and the main reason is we don't have alimentary limb. Alimentary limb makes the, the bowel transit slower, okay? Alimentary limbs, they increase a lot the production of SGLT2 receptors, and that bowel has a high consumption of glucose from the side of the blood, and it can cooperate and be at least part of the issue of the hypoglycemia. So I don't like nowadays, if I can, I avoid biliopancreatic lymph. And if I do those, and I'm doing those in the classical transit by partition that I'm performing nowadays, I do it only with 30 centimeters in order just to remove bile from the stomach.
Sir, excellent. Sir, regarding weight regain after Roux-en-Y gastric bypass, so patient after 5 to 6 years, so now weight regain. So you have decided to go for so this revision now interventional. Yes, definitely we rule out that dilation of gastric pouch. We must rule out that gastrojejunostomy.
And
Uh,
gastrographic fistula.
yeah, gastric fistula, you ruled out these things. Yes, okay. And because previous the BP limb was because that was the standard 75, 80, and also rule limb was 80. But now you have decided. So in such a situation when you decided to go and now BMI is about 40 again, and diabetes come back, and so the patient 50 plus. uh, what is your opinion about distalization in such a situation? And what is your
I,
standard?
I can tell you my opinion and my experience also. Fortunately, I've done a lot of work on that in that situation. Well, because I've been performing Roux-en-Y bypass since 2000, end of 2001 up to 2010, and I continued to do some after that, but decreasing the rate of. So I had to revise a lot of Roux-en-Ys with weight regain. In the beginning, I've done some kind of distalizations, mainly Sugarman, okay, type 2
Yeah.
distalization. And what have I seen? Some people were good. They were losing good weight loss, but some people were losing too much weight with malnutrition, with hypoproteinemia, and anemia and so on, and with acidic smell because of the cetoacidosis and so on. And some people didn't lose weight. If we do it a little bit short, it doesn't work. If you do it a little bit longer, it works too much. So it's not reliable. So it was difficult to measure the bowels properly. I tried also a kind of concept that was developed in Brazil. It is the scopinarization of the bypass. Okay, it's another kind of distalization with the same problem. Because of that, I have, at least I remember, 3 patients that I have done a distalization, and because of excessive weight loss, I need to revert back and elongate again the common limb in order to save the patients, and they are good, fortunately. Well, that was the first time. Of course, there was a time when I tried to, and some kind of patients, to reestablish some restriction. I used rings, for instance, even bands, in order to put, and trimmings. I've done a lot of a lot. I mean, about probably between 15 and 20 cases of duodenal gastro. How is it? The sleeve, the sleeve duodenal trimming. Oh, I mean the trimming of the candy cane, the anastomosis, and the pouch. Okay, making the pouch thin again. That's an operation published by Michel Gagne, I suppose, and I've done some. Okay, and that's the concept. The patients were losing some weight in the beginning, but afterwards they recovered because it was restriction only, not more than that. In some patients, I associate restriction and some visualization. Okay, but not again. I could not say to patient, I'm going to lose, I'm going to get that goal. So it's somehow imprevisible. Well, in the more recent years, I began to convert and it was only, I suppose, in the last 3 years, converting bypass, because I had to convert a couple of cases from urinary acid bypass to sleeves because of hypoglycemia, and one case because of anemia. I was used to do the gastrogastric reconstruction and sleeve and resleeve. I began to convert them to TADS or to transit by partition. Those are my favorite option in the scenario that you draw in the so patient with weight regain some years after with no big problems, with no excluded other causes of weight regain. Those are the best operations for me, by partition or SADS. You need to resect the anastomosis. You need to deal with the alimentary limb. You have two options, or you leave the alimentary limb by itself. So I would say blind, but there is no big issue, as I was discussing with Bruno Dillmans some weeks ago, because it is isoperistaltic and will empty very easily, and you have the bowel still live into the belly, or you can put it in transit. You have to perform one more anastomosis, but you can save it and restore the complete continuity of the bowel. I do prefer that one. And after that, you do the gastrogastric anastomosis. What I can say, it's tricky, it's not easy, but the best way to do it is to join the tip of the pouch, resected anastomosis upper limit, with the remnant in the lesser curvature, terminal, I would say, in manual anastomosis. I've done before with the circular, but there is a tendency to shrinking of anastomosis and stenosis. So do it manual and a bit larger, I would say with 4 centimeters at least, 4 or 5. And after that, you can do the sleeves. You can sleeve the remnant and remove all the excessive stomach. There is an important problem, because in the corner of the sleeve in the anastomosis, there can be a place, a spot of hypoxemia and tissue necrosis, tissue hypoxemia and necrosis. So we need to be careful about that. If possible, use ICG. It helps a lot in detecting that kind of failure of the vascularization in that corner. And also because of that, in the Madrid group from Antonio Torres and Sanchez Pernalte, what are they doing? They do this and they don't make the trim immediately. They go there, they perform the SADS, and they go there 6 months later to make the sleeve. And because of the revascularization of that corner, there will be no risk. And they do that because they have some fistula, some leaks that are not easy to deal with. So after making the reanastomosis, the gastrogastric reanastomosis and the sleeve, you go to the SADS, to the duodenal ileal anastomosis, and it's done. There is another option that has been promoted by Victor Dib in Brazil, from Manaus in the Amazonia, and he has done this with the jejunal bridge. Instead of performing a gastrogastric anastomosis, mainly in very short pouches, it doesn't touch the pouch or the gastroenterostomy. It just cut the alimentary limb and anastomosis the alimentary limb to the antrum of the remnant. and he is getting the I would say the continuity of that, but putting in the middle a piece of the elementary limb. He has published that a paper with that technique very recent. I am co-author because I assisted him in the paper, and it's an interesting technique. Of course, we need to protect the question about the acid in the bowel, so because it can provoke erosion and hemorrhages in the future.
Sir, excellent. Sir, one question about this last technique by Victor Deeb from Brazil. So when he will do enterojejunostomy, okay, and just imagine also attach that he did gastrostomy because he attached the pouch. There will be lot of acid production. There is more chance of marginal ulcer in such a situation. Are you agree?
Yep, I agree. That's it. I do agree. Acid ulcer mainly in the bowel segment,
Yeah.
but
Yeah, yeah.
also in the rest of the stomach, of course, but mainly in the bowel.
Oh,
That technique was not invented by Victor Deep. That technique was in reality promoted in Brazil only. I didn't know anyone doing that in other parts of the world by Alcides Branco, another excellent surgeon from Brazil, very spectacular, very quick, very safe. That was doing that kind of reconstruction for hypoglycemia in monogastric bypass. But because of problems with the bowel segment, he quitted from that technique.
agree. Definitely, sir. Regarding this one, anastomosis, gastric bypass, that is also one of my really personally. So my I like this surgery, and my main practice is the anastomosis. So, have you faced any intractable GERD? When we ask intractable GERD, so patient has symptoms of reflux. That is not bile reflux. That is not bile reflux. So when you will do endoscopy, definite. Routinely, we see bile in stomach. Definite, we must see. And that is also physiologic. When we are doing in normal cases also, bile is in stomach. Bile in stomach is not issue. But bile in esophagus is issue. Definite.
Yeah.
Patient is suffering with intractable GERD. That was standard for anastomosis or MGB by Professor Riberio. Have you faced such a situation, and what was your what you did for that case?
Okay, OAGB with the bioreflux, that's it?
Yeah.
Yeah. Okay, what do I do? Diverted OAGB. That's how it was born in 2013. I can tell the story. I was operating Angola is a country that was a former Portuguese ex-colony, and the bigger and the main city is Luanda, the capital. And I had with me in Lisbon the Luanda governor, a very, very important and rich guy. And he asked me to operate on gastroesophageal reflux. He had a somehow big hernia. I had a hernia, and I want to treat but it was big and heavy, 120 kilos. And I thought, well, the better solution would be to repair the hernia and to do a gastric bypass. And I told him, well, the best gastric bypass is OAGB, but there is a risk of having some bile in the esophagus later on. Why it can happen, but it's easy to solve. It happens in 6% of the patients, the maximum, but it's easy. We go in a second operation, you just divert, cut there, anastomosis there, and it's solved in 100% of the cases. And he told me, well, but if it is that way, why don't do that as the first intention operation? You see, well, the guy is right. So I began to do that. So if I have a patient like that, I would go for a diversion of the bile, doing the cutting the afferent limb close immediately before the gastroiliac anastomosis, and to reanastomose it 1 meter down. In the beginning, I began with 60 centimeters, but I have a couple of cases, 2 cases that the bile was able to go back still. After that, because of after Professor Rudolf Weiner counseling, I went to 80. And finally, I found 2 articles, 2 papers in literature talking about 1 meter, and I finished with 1 meter. So even nowadays, when I do it, more scarcely. I do it with 1 meter of, I would say, alimentary.
Sir, excellent, sir.
But a little bit more. But if there is a more important situations like a Barrett's esophagus or a grade C or D, Los Angeles, esophagitis, I defend more the patient and I do it, but with a smaller, I cut the pouch and do a smaller pouch in order to reduce the acid production more.
Sir, my question regarding this diverted OAGB. So we have, first my question, how many cases you did till this time? This and next question, so about marginal ulcer, because this is definite Roux-en-Y gastric bypass with long and big pouch. There is definite more acid production. There is more because bile is buffering. There is no buffering effect of bile because in OAGB definite we have a long and bigger pouch, but due to bile and buffering effect of bile, we can face less marginal ulcer due to acid. But in this technique, then there is no bile in stomach, only acid production. Just imagine this is a Roux-en-Y gastric bypass with longer and bigger pouch. So what is so how many cases you did, and also what is the percentage of marginal ulcer?
Well, I published in 2019, so patients up to 2018, 400 cases, and probably I've done more 100 only, exactly because of what you said. Indeed, it's an increased risk, there is an increased risk of marginal ulcer, and I had some, but not a lot of cases. I would say that I need to say before that all my patients since that time, I'm giving them PPIs for 1 year. Okay, I completely exclude patients that they are smokers or alcohol drinkers, heavy drinkers, or patients taking anti-inflammatory non-steroid drugs, or patients with intractable Helicobacter pylori infection. So all those cases I do remove from OAGB, so and diverted OAGB. So it can reduce the rate, but even though the rate should be about 2 or 3% of the cases. And yes, I have some cases of ulcers more difficult to deal with. I had only one perforation, not one perforation exactly, but contained in the gastric wall, not with dissemination. But I found that I had some cases of one case of stenosis because of the ulcer, and other more difficult cases of more difficult to treat cases. So, and that's why I'm doing just a few cases of diverted OAGB, probably in the case of sleeve with reflux and weight regain, but just a few. So I quit my own operation, I would say.
Sure, sir. Sir, regarding, because now your main practice is OAGB, and have you faced any severe malnutrition or severe weight loss? And if you faced, what was your strategy in those cases?
I suppose I had all my life 5 cases of, I would say, hypernutrition in the OAGB. The first one was an old lady that operated with 65 years old from the south of Portugal in a area where people, they do eat very badly. They eat mainly bread and fat
Carbs.
meat, the carbs and the fat. So that patient, she went home, and after 1 year, she came back with an anemia, an important anemia. It was not hypoproteinemia, it was anemia, iron deficiency, and because she was not eating enough red meat or equivalent. And okay, we treated the anemia. She went back home, and after 2 months, she came back another with the anemia. So I decided to revert the operation. She was then 67 years old, and I suppose the problem is age. And that's my first message. Don't perform OAGB and in older people, because they don't adapt so well. About the bowel doesn't adapt so well. It's not able to recover the absorption capacity, and some of them will fall in hyponutrition. Okay, that was the first case. After that, I had two cases of people that had cancer suspicion. One suspicion, and the other one had another cancer, breast cancer, a woman, and they were too thin and hypoproteinemic. They were not eating well, and I decided to. In one case, I just shrink the biliopancreatic limb, make it very, very short, and the patient recovered well. And the other case, I reverted to the normal anatomy, a reversion. Okay. And the last one, three cases, the fourth I'm not remembering. The last one I remember very well. It was a couple. I operated the husband, the man. He was a very big guy, and he went very well. And because of that, the lady that was not so big, she was a BMI about, I suppose, 34, 35, 33, around that. She asked to the operation. Okay, she was not a difficult case, but I was not able to understand that she was a workaholic woman. I performed the OHGB. She went well in the beginning, but suddenly after 1 year, she was with a BMI of 19, very thin, 47 kilos, 45 kilos. And when I understood the situation, she was working 14 hours a day. She was not eating. She was drinking about 20 coffees a day and smoking 2 packets of cigarettes each day, and not eating because of that. So the problem was not the operation, was her mind in that case. The power of mind would be great in that patient. But before falling any kind of malnutrition in a good condition, I decided to revert to the normal anatomy. Inclusive, she was not, she could not afford enough money for that, but I do it for free. And I asked the hospital to do the same in order to put them in to put the lady in safety land, I would say. Well, it's important here that to say that we need to, if we have a patient with malnutrition, and if you want to reoperate him or she, we need to be careful about nutritional status and look at proteins, albumin, PCR, and of course anemia and all the vitamins and minerals. And it's very advisable if there is an hypoproteinemia to perform nutritional reestablishment of the situation, to put the patient with your nutritionist in refooding process, or if necessary, put the patient on total parenteric nutrition for at least 1 week or 10 days before the operation, trying to operate, because the risk of failure and complications, mainly leaks, is very, very high.
Sir, so much thanks really, and definitely it was one of the best session, no doubt, because this is a personal experience, and in my opinion, we are at least 5 years ahead to the text. Because my viewers, so these live discussion, this was our main theme, to interview such a legendary bariatric surgeons. So just imagine, so we are talking with Professor Rui Rubirio, he's sharing his knowledge, he's sharing his experience, but unfortunately in webinar, because we don't have such a time, so maybe 5 to 10 minutes, but this interview session, yes, we have sufficient time. This is a friendly, really, and also relaxed mood, and also share the knowledge, and definite this will be a message for our youngsters. Sir, so much thanks really, and it was definitely, it was one of the best session. Sir, message for our youngsters who are just now going to start revisional. They are doing bariatric surgeries, but they are also going to go inside this game as well for revisional bariatric surgery. Any message for such a youngster?
Yeah, the message is be brave surgeons, try to be brave surgeons, but be careful also. Be very well balanced about your decisions. As I said before, if measure very well your capacities, and for more important cases, more difficult cases, ask for help from someone. And even if they are not so difficult, please study a lot. Think about the technical aspects that we have commented and other ones, and try to be safe with your patient, or keep your patient in safe range, because don't forget that revisional surgery has 4 or 5 times more complications than primary surgery, and that's the problem. And some patients, they need 1 revision, 2 revisions, sometimes 4 revisions, but there is a time when we should stop. When a patient is not doing bad with the 3rd or 4th, or even on the 2nd revision, please stop, because maybe the problem is the patient, not the operation.
Sir, so much thanks. So much thanks, my viewers. So this session is due to your follow-up. If you have any question from Professor, you can ask in comments. And definite Professor will respond, and we will continue this revisional bariatric surgery next week, Tuesday at 10 p.m. Dubai time. We will be with another legendary bariatric surgeon. Sir, again, so much thanks. And definitely in future, we also need your support, your guidance.
Tom, thank you so much. It was a pleasure and an honor to be with you and all you guys. Thank you so
Thank you.
much. See you later on.
Thank you, sir.
Bye-bye.
Have a nice time.
Thank
Sir.
you.